Start with the section 7 of your Apurba S Sastry Essentials of Microbiology textbook, which will be skin, soft tissue, and musculoskeletal system infections. In this, we'll be studying the chapters from 50 to 58. The chapter 50 will be about the infective syndrome of skin, soft tissue, and musculoskeletal system, which we'll be covering in this video. Next, 51 will be about staphylococcal infections. Next will be about beta hemolytic streptococcal infections. Next one will be about gas gangrene, Clostridium perfringens, and infections due to the non-sporing anaerobes. 54th will be about leprosy. 55th will be about miscellaneous bacterial infection of skin and soft tissues, anthrax, bacillus anthracis, actinomycosis, nocardiosis, non-venereal tryponematosis, and others. 56th will be about viral exanthems and other cutaneous viral infections. 57th will be about parasitic infections of skin, soft tissue, and musculoskeletal system. And 58th will be about fungal infection of skin, soft tissue, and musculoskeletal system. Okay, so now this is given for multi-drug resistant organisms in hospital. You have to stop the spread of these, right? So contact precautions, like everyone must clean their hands, including before entering and when leaving the room, and providers and staff must also put on gloves before room entry, discard the gloves before room exit, put on gown before room entry, discard gown before room exit. Do not wear the same gown and gloves for the care of more than one person. Use dedicated of disposable equipment. Clean and disinfect reusable equipment before use on another person. Okay. Now let us start with chapter 50, which is infective syndromes of skin, soft tissue, and musculoskeletal system. In this chapter, we will be covering the skin and soft tissue infections in summary, and also the musculoskeletal infections. Introduction. Approximately 15% of all patients who seek medical attention have some skin disease or lesions, out of which many are infectious. Before discussing various skin and soft tissue infections, understanding the structure and function of skin is important so that it can be related to the pathogenesis of the disease. Anatomy of skin. The skin comprises of epidermis, dermis, and subcutaneous tissues. The epidermis is made up of several layers of squamous epithelium. From superficial to deep, the layers are called as stratum corneum, stratum lucidum, stratum granulosum, stratum spinosum, and stratum germinativum, also called as stratum basale. The dermis is composed of dense connective tissue rich in blood and nerve endings, and is the site of origin for some superficial hair follicles and sebaceous glands. The subcutaneous tissue contains loose connective tissue and is rich in fat. Deeper hair follicles and sweat glands originate in this layer. Facial layer is present below the subcutaneous tissue. It is made up of sheets or bands of fibrous tissue covering the muscle, ligament, and other connective tissues. Physiology of skin. The skin is the body's largest and thinnest organ. It performs various functions. It serves as an anatomical barrier and protects the internal organs from external environment. Its other functions include the control of body temperature, excretion of water and salts, synthesis of important chemicals and hormones, and also acting as a sensory organ. The skin's normal microbial flora, pH, and chemical defenses, high salt and acidic environment also help to prevent colonization by many pathogens. Normal resident microbial flora of skin include coagulase negative staphylococci, including staphylococci epidermidis, micrococci, diphtheroids, and anaerobes such as Propionibacterium acnes. Okay. In this diagram, we can see the epidermis, the dermis, which contains the sweat and sebaceous glands, the subcutaneous tissue, also the hair follicle with the hair. Below subcutaneous tissue lies the fascia, the muscle, and the bone. So let us start with skin and soft tissue infection, SSTIs. Skin and soft tissue infections constitute a major infective syndrome. SSTIs can arise from invasion of organisms through skin due to the breach in anatomical barrier or from the hematogenous route secondary to any systemic infection. Clinical manifestations. Various terms are used to describe skin manifestations which differ from each other by the clinical appearance. The terms most frequently used to describe manifestations are listed in the table, which can be classified into the primary skin lesions and the description and the common organisms implicated. Now let us see the macule. It is a flat, non-palpable discoloration of skin less than 5 mm in size. If size exceeds 5 mm, it's called a patch. Okay. The common organism involved are dermatophytes, Treponema pallidum, secondary syphilis, and viral rashes, example enterovirus. Papule is an elevated palpable solid lesion usually less than equal to 5 mm in size caused by molluscum contagiosum, scabies, warts, human papilloma virus. Nodule is elevated palpable solid lesion usually more than 5 mm in size. If size is more than 2 cm, it is called a plaque. Corynebacterium diphthery, Sporothrix skenchi, post Kala azar dermal leishmaniasis, Mycobacterium marnium, nocardia species. Vesicle, fluid filled blister of size less than equal to 5 mm, HSV, VZV, Molluscum contagiosum, hand foot mouth disease, Coxsackie virus A16, and Rickettsia acari rickettsial pox. Bulla, fluid filled blister of size more than 5 mm, Clostridium species, gas gangrene, HSV, Staph aureus, Bullous impetigo, and scalded skin syndrome, Vibrio vulnificus, and other gram negative rods. Pustule pus filled lesion of size less than equal to 5 mm, Candida Staph aureus folliculitis, HSV, Staph pyrogens, Staph aureus, impetigo, and dermatophytes. Abscess, pus-filled lesion of size more than 5 mm, Staph aureus, Staph pyogenes, and others. Fatigue, extravasation of blood into skin of size less than 2 mm, HIV, hepatitis C, EBV, rubella, CMV, or RMS fever. Purpura, extravasation of blood into skin of size 2 mm to 1 cm, CMV, endocarditis, meningococcemia, mononucleosis, RMS fever, scarlet fever, sepsis, viral hemorrhagic fevers. Ecchymosis, extravasation of blood into skin of size more than 1 cm, Ebola and Marburg viral hemorrhagic fevers. Now the secondary skin lesions and their description. Scales, flakes arising from horny layer caused by dermatophytes. Ulcer, a lesion with loss of epidermis and dermis caused by Mycobacterium leprae, leprosy, Mycobacterium ulcerans, Bruley ulcer, Yersinia pestis, bubonic plague, Haemophilus ducreyi, cancroid, and Treponema pallidum, hard cancre. Eschar. It is black dead tissue formed in full thickness wound. Bacillus anthracis, cutaneous anthrax, scrub typhus, rickettsial pox also seen following burn injury. Crusted lesion, scale-like lesion composed of dried blood and tissue fluid. Common organisms implicated are Bullous impetigo, Ichthema, Staph aureus, Impetigo contagiosa, Staph pyogenes, ringworm, dermatophytes, and cutaneous leishmaniasis. These all called crusted lesions. Okay, abbreviations: RMS for Rocky Mountain Spotted Fever, CMV for cytomegalovirus, HSV for herpes simplex virus, VZV for varicella zoster virus, and EBV for Epstein-Barr virus. Now, the primary skin lesions are the direct result of underlying disease process and are of diagnostic importance. Examples include macule, papule, nodule, plaque, vesicle, bulla, pustule, abscess, purpura, fatigue, and ecchymosis. Secondary skin lesions, they evolve from primary lesions by self-trauma or altered keratinization. Common examples include scales, ulcer, eschars, and crusted lesions. Classification of SSTIs. SSTIs can be classified into various types. Infection of dermis and epidermis, infection of skin appendages such as hair follicle, sebaceous gland, sweat gland, and nail. Infection of fascia, example necrotizing fasciitis. Okay. Wound infections such as surgical site infection, bite wound infection, burn wound infection, and infections of sinus and fistula. SSTIs due to vascular injury and neuropathy, diabetic foot ulcer and decubitus ulcer, cutaneous manifestation of systemic diseases, lymphadenitis and lymphangitis. Infection of dermis and epidermis occur due to traumatic breach in skin which results in inoculation of microorganisms. Various types are erypsils, erythrasma, erypsiloid, impetigo, and cellulitis. Infection of skin appendages, infection associated with hair, folliculitis, furuncle, carbuncle. Okay, now the table about infections of epidermis and dermis. Ringworm or tinea infection, Because of their ability to utilize keratin, they infect keratinized layer of epidermis, skin, hair and nail. They do not invade beyond the superficial layer of skin. The skin lesions appear as annular or ring-shaped pruritic, scaly with central clearing and raised edges. Scaling, erythema or rarely blister formation may occur. Organism involved dermatophytes, trichophyton infects skin, hair and nail. Microsporum infects skin and hair. Epidermophyton infects skin and nail. Deep epidermis and dermis. Impetigo erythematous red lesions that may be either non-bullous, more common, or bullous, that rupture and develop into honey-colored crust, commonly affect young children, most commonly found on the face. Staph pyogenes, common agents, and Staph aureus for bullous impetigo. Erypsales, non-necrotizing inflammation of dermis and subcutaneous tissue. Lesions are painful, red, swollen, and indurated with distinct border. Patient may also have fever and regional lymphadenopathy caused by Staph pyogenes, common agent, and Staph aureus occasionally. Erythema, chronic infection of keratinized layer of epidermis. Lesions are dry, scaly, itchy, and discolored reddish brown. Corynebacterium minutissimum, common in diabetics. Erysipeloid, purplish red, non-vesiculated skin lesion with an irregular raised border. The lesion itch and burn, fever, and other systemic symptoms are uncommon. Erysipelotrix ruseopathiae. Okay. Cellulitis, diffuse spreading infection involving the deeper layers of dermis. Lesions are ill-defined, flat, painful, red, and swollen. Patients have fever, chills, and regional lymphadenopathy. Commonly caused organisms are Staph pyogenes and aureus. Less common are Aeromonas, Vibrio species, and Haemophilus influenzae. Now coming to the infection of skin appendages. Infection of hair follicle, folliculitis, superficial infection of hair follicle, presents as papule or pustule. Staphylococcus aureus most common, hot tub folliculitis, Pseudomonas aeruginosa. Furuncle or boil, deeper infection of hair follicles that begins as red nodule and then becomes painful and full of pus, caused by Staph aureus. Carbuncle, furuncles that coalesce and spread more deeply into the dermis and subcutaneous tissue, usually have multiple sites which drain into the skin surface. Sinuses, caused by Staph aureus. Infections of sweat gland, hidradenitis. Okay, chronic hidradenitis, chronic infection of obscurated apocrine sweat glands in the axilla, genital, or perianal areas with intermittent discharge, often foul smelling pus, caused by Staphylococcus aureus, Streptococcus agalacti, anaerobic streptococci, and bacterioid species. Infection of sebaceous gland, sebaceous cyst. Generally, sebaceous glands empty into hair follicles and ducts. If these portals get blocked from sebaceous cyst, they may become secondarily infected and cause staphylococcal abscesses. Causing agent as Staphylococcus aureus. Infections of nail, onychomycosis, fungal infection of nail characterized by discolored, thick, fragile, or cracked nails. Causing organism is Taenia unguium dermatophyte, Candida albicans. Green nails separated from nail bed become green with foul odor. Causing agent is Pseudomonas aeruginosa. Okay, so continuing the infections of skin appendages, as already said, infection associated with hair folliculitis, furuncle, or carbuncle, and infection of sebaceous gland, infection of sweat gland, hidradenitis, and infection of nail, onychomycosis. Okay. Next, coming on to infection associated with subcutaneous tissue. Infections of the subcutaneous tissues may manifest as abscesses, ulcers, or boils. In many instances, infections of the epidermis and dermis extend deeper or become subcutaneous infection. For example, cellulitis may extend to subcutaneous tissues. The organism isolated from the subcutaneous abscesses depend on the site of infection. Staphylococcus aureus remains the most common etiologic agent of subcutaneous abscess. Anaerobes are commonly isolated from abscesses of the perianal, inguinal, and buttock areas, whereas non-perianal infection is commonly caused by mixed infections containing facultative organisms. Menley's ulcer, also called as progressive synergistic gangrene, is a slowly progressive chronic infection of the subcutaneous tissue that usually begins as an ulcer following trauma or surgery and may lead to subcutaneous necrosis. They occurs through polymicrobial infection in which microaerophilic streptococci grow synergistically with Staph aureus and also other facultative or anaerobic organisms. Specimen should be taken from the advancing outer edge of the lesion, not from the central portion of the wound, for better recovery of microaerophilic streptococci. Anaerobic cellitis. It is associated with the production of large amount of gas by organism that may be present in the subcutaneous tissue. This type of infection is most often located in extremities and is particularly common in diabetics. Infection of fascia. Necrotizing fasciitis. Necrotizing fasciitis is a serious life-threatening condition which involves infection of the fascia and often with the overlying soft tissue. As no barrier exists to prevent the spread of infection or at the fascial level, so fasciitis may extend widely and rapidly to involve larger areas of the body in a short amount of time. Agents. Most common organisms associated with necrotizing fasciitis are group A streptococci, Staph aureus or anaerobic bacteria, especially bacteroids and Clostridium species. Fournius gangrene. It's a rare and often fulminant necrotizing fasciitis of perineum and genital region, frequently due to synergistic polymicrobial infections comprising of mixed aerobic and anaerobic bacteria. Now coming on to wound infections, post-operative surgical site infections. They are among the most common healthcare associated infections and occur after nearly 3% of all surgical procedures. The source of infection in SSI include the patient's own flora present on the skin. Staph aureus is the most common organism causing SSI or mucosa E. coli or anaerobe for gastrointestinal mucosa or environmental source gram-negative bacilli such as Pseudomonas and Acinetobacter. SSIs can cause significant morbidity and mortality as well as economic burden if left untreated. Next, the bite wound infections. Bites and scratches from animals and humans allow the inoculation of microorganisms present in the saliva to breach the skin's protective barrier into deeper susceptible host tissues. Most common bites are from dogs and cats. This leads to various infections ranging from cellulitis at the site of bite to systemic infections such as bacteremia or even encephalitis and rabies. Common infections transmitted by the dog bite include Pasteurella and capnocytophaga, and rabies. Burn wound infections. Their thermal burn injury may cause massive destruction of the skin and its appendages, as well as impairment of the immune system, both humoral and cellular immune systems. Infectious complications are the major cause of morbidity and mortality in serious burn injuries. Loss of the cutaneous barrier facilitates entry of patient's own endogenous skin flora and organisms from the hospital environment into a burn wound. Pathogenesis. Initially, the burn wound is colonized with gram-positive bacteria, example Streptococci and Staphylococci, from the surrounding tissue, reaching to the maximum load beneath the burn wound on day 4 after the burn injury. An estuary is formed over the burn wound, which is usually avascular because of the damaged blood vessels caused by the burn injury. The avascularity of the estuary, along with the impairment of local immune responses, favor further bacterial colonization and proliferation. By day 7, the wound is colonized with other microbes from the gastrointestinal and upper respiratory flora or also from the hospital environment. Most common organisms implicated being Pseudomonas aeruginosa, Acinetobacter, E. coli, Klebsiella, Staph aureus, and fungi such as Candida aspergillus species, and the agents of mucormycosis and viruses such as herpes simplex virus. The clinical presentations. Burn wound infection may present in 4 forms: burn wound impetigo, surgical site wound infection, pleurient infection of the excised burn wound site and graft site, cellulitis when burn wound extended to surrounding healthy tissue, and invasive infection in unexcised burn wounds. Green discoloration of the wound point towards the Pseudomonas aeruginosa infection. Lab diagnosis. Although burn wound infection is diagnosed clinically, laboratory has a role to identify the causative organisms so as to guide antimicrobial therapy. Appropriate specimen include pleurient wound exudates, tissue biopsy specimen, and blood cultures. Surface specimen should be collected with a moistened sterile swab using a minimal amount of pressure. Sometimes a quantitative culture of a tissue biopsy specimen is performed to assess the severity of infection or to identify the most prevalent organism in a polymicrobial infection. Result of more than 10 to the power 5 CFU per gram of tissue is indicative of potentially serious infection. Burn wound infections. The successful burn wound management comprises of the components, following components: early surgical excision of the burn tissue, extensive debridement of necrotic tissue, grafting of skin or skin substituents from autograft or compatible allogenic graft, topical antimicrobial agents like silver sulfonazide cream, mefenazide acetate cream, silver nitrate cream, and nanocrystalline silver dressings. Systemic antibiotics may be useful if sign of systemic involvement is present. However, prophylactic systemic antibiotics have no role in the management of burn wounds and in fact can lead to subsequent colonization with resistant bacteria. Sinus tract and fistula infections. Sinus tract, a deep-seated infection, example osteomyelitis, may occasionally develop a channel called as sinus tract to the skin surface, which helps in draining the fluid and pus onto the skin. The organisms frequently involved in sinus tract formation with the underlying osteomyelitis include Staph aureus, most common, gram-negative bacilli, and anaerobes. Chronic draining sinuses may also be found in patients with tuberculosis and non-tuberculous mycobacteria infection, nocardia infection, actinomycosis, and infections associated with implanted foreign bodies. Curating or biopsy specimen from the debrided, cleansed sinuses tract should be collected for culture. Fistulas. These are abdominal channels connecting the epithelial surfaces either between two internal organs or between an organ and the skin. Examples include perirectal fistulas from the small bowel into the skin associated with Crohn's disease or chronic intra-abdominal infection. When the bowel is involved, the associated underlying cause may be tuberculosis, actinomycosis, or malignancy. Biopsy is the specimen of choice. Specimen collection is a challenge due to the presence of indigenous bowel flora. Skin manifestation of systemic infections. Cutaneous manifestation of systemic infections may be important clues for the clinician. For example, meningococcemia may be associated with fatigue, tiny red hemorrhagic spots on the skin. Scraping of fatigue may demonstrate the presence of gram-negative diplococci, various organisms involved in systemic infections capable of producing cutaneous lesions are cocci such as meningococci, streptococci, Staph aureus, and gonococci. Gram-negative bacilli such as Pseudomonas, Bacillus pseudomyeli, Vibrio vulnificus, and Salmonella typhi, rose spots. Mycobacterium tuberculosis, Lupus vulgaris, and Mycobacterium leprae, Rickettsial Bartonella, and Streptomycillus moniliformis, viral hemorrhagic fever and exanthemis viral diseases, fungi, Candida, Cryptococcus, Histoplasma, Blastomyces, and coccidioides. Okay. Now the diabetic foot ulcer. Patients with diabetes mellitus have high risk of developing infection, especially in the lower extremities. If not promptly managed, can lead to amputations and greatly increased mortality. Pathogenesis. The excess blood glucose can result in impaired microvascular circulation and peripheral motor neuropathy. Subsequently, any skin damaging injury or surgery greatly increases the risk of contracting infections. The foot ulcer of diabetic patient does not heal as quickly as that of a healthy individual. Lab diagnosis. The following specimen may be subjected to culture: aspirated fluid or pus taken from a deep pocket within the wound or debrided infected tissue. Wound swab from the ulcers is not an ideal specimen. Microbiology. The most common bacteria isolated include Staph aureus, group B, Streptococci, members of the Enterobacteriaceae, Pseudomonas aeruginosa, and anaerobes, example Bacteroides fragilis. The majority of severe infections are usually polymicrobial. Now coming to decubitus ulcer. Elderly or chronically ill bedridden patients are prone to develop decubitus ulcer, also called as bed sore or pressure sore. The most common site being near the anus or the lower extremities. Most frequent organisms infect the decubitus ulcer are gastrointestinal flora. Example, Bacteroides. This is a diabetic foot. Bacteroides fragilis or nosocomial pathogens. Example, Staph aureus or Pseudomonas aeruginosa. Lymphadenitis and lymphangitis. Lymphadenitis is the inflammation or enlargement of the lymph nodes. Lymph nodes are small ovoid nodules distributed in clusters along the course of lymphatic vessels located throughout the body. The primary function is to filter out organisms and abnormal cells in the lymph fluid. Etiology. Lymph node enlargement is a common feature in a variety of diseases which include infection, immunologic disorders, disease of lymphoid or reticular endothelial tissues, and malignancies. Infections. Lymphadenopathy may be seen in various bacterial, viral, parasitic, or fungal infections. They represent a benign response to localized or systemic infection and may serve as a focal point for subsequent clinical investigation. Lymphadenitis may affect a single node or a group of nodes, regional lymphadenopathy, unilateral or bilateral, soft or hard, indurated, painful or painless. The onset may be acute, subacute, or chronic. Lymphangitis. It is defined as an inflammation of the lymphatic vessels that occurs as a result of infection at a distal site to the vessel. Etiological agents include group A beta hemolytic streptococci, most common cause, and Staphylococcus aureus. Gram-negative bacilli and fungi may cause cellulitis and resultant lymphangitis in immunocompromised host. Pasteurella maltopsida, associated with dog and cat bites, can cause cellulitis and lymphangitis. Aeromonas hydrophila can contaminate wounds that occur in fresh water. Lymphatic filariasis due to Wucheria bancrofti and Brugia malae. They are the major cause of acute lymphangitis worldwide. Signs and symptoms of lymphangitis caused by Wucheria bancrofti are indistinguishable from those of bacterial lymphangitis. Nodal lymphangitis commonly follows the superficial inoculation with one of the following organisms: Sporothrix skinchi, Nocardia barziliensis, Mycobacterium marnium, Leishmania paramensis, and Leishmania guinesis, and Francisella tularensis. Okay, in addition, individuals with diabetes, immunodeficiency, and chronic steroid use or other systemic illnesses have increased risk of developing serious or rapidly spreading lymphangitis. Okay, so this covers our SSTIs. Now coming on to musculoskeletal infections. Musculoskeletal infections include infections associated with muscle, myositis, myonecrosis, and infections associated with bone, osteomyelitis, joint infection, and septic arthritis, and bone marrow. Okay, so before we continue that, let us see this infectious agents causing lymphadenitis. Bacterial causes: Bartonella hensel, cat scratch disease, single node at scratch site, discrete mobile, non-tender. Okay, Francisella tualarensis or the tualaremia, okay, is cervical, mediastinal, or generalized tender lymph nodes. Atypical: Mycobacteria, cervical, submandibular, submental, unilateral. Mycobacterium tuberculosis, mediastinal, mesenteric, anterior, cervical, tender, discrete, firm, mobile, hematogenous spread. Salmonella generalized. Staph aureus adenitis and Staph pyogenes pharyngitis, cervical, submandibular, unilateral, firm, tender. Yersinia pestis plague, axillary, inguinal, femoral, cervical, extremely tender. Yersinia enterocolitica, cervical or abdominal. Viral causes: cytomegalovirus generalized, Epstein-Barr virus, infectious mononucleosis, anterior cervical, mediastinal, bilateral, discrete, firm, non-tender. Parvovirus and rubella virus, posterior auricular, occipital, posterior cervical. Parasitic organisms: Toxoplasma gondii, generalized, often non-tender. Fungal causes: coccidioides and histoplasma, mediastinal, subauric dermatitis, occipital and post-auricular. Now coming back to musculoskeletal infections, the infection of muscle. Infectious myositis, inflammation of the skeletal muscle, can be caused by a variety of organisms. Bacterial myositis, present in several forms caused by various organisms. Staph aureus myositis is the most common cause of acute bacterial myositis resulting from hematogenous spread. Pyomyositis refers to the focal collections of suppuration of in muscle, most often caused by Staph aureus. Psoas abscess. It's a retroperitoneal collection of the pus in iliopsoas muscle compartment, most commonly caused by Staph aureus. Other agents include Streptococci, E. coli, and Mycobacterium tuberculosis. Streptococcal necrotizing myositis due to Streptococcus pyogenes or Streptococcus agalacti. Clostridial myositis and gas gangrene is a edematous myonecrosis caused by Clostridium perfringens, most common, or other Clostridia species. It follows severe penetrating injuries that result in interruption of blood supply and introduction of soil into wounds. Synergistic non-clostridial anaerobic myonecrosis. Others: Aeromonas bacteroides, Burkholderia, Pseudomyeli, and Vibrio vulnificus, etc. Viral myositis. Viruses implicated in the pathogenesis of myositis include HIV, human T lymphotropic virus HTLV, influenza, dengue, Coxsackie virus, and echoviruses. Parasitic myositis, parasitic infections such as Chagas disease, cysticercosis, trichinellosis, and associated with myositis. Fungal myositis usually occur in an immunocompromised host. Causative agents are Candida species commonest, Cryptococcus neoformans, Histoplasma capsulatum, Coccidioides species, or Aspergillus species. Infections of skeletal system. Osteomyelitis. Osteomyelitis is inflammation of the bone caused by an infecting organism. Pathogenesis organism may spread to bones either due to direct invasion, secondary to events such as trauma, surgery, joint infection, presence of foreign bodies, prosthesis, or from hematogenous spread. Once established, the infections in the bone may progress towards the chronicity, particularly if the blood supply is insufficient in the affected area. Agent Staph aureus is the most common cause of acute osteomyelitis, followed by streptococci and gram-negative bacilli, mainly E. coli and Pseudomonas aeruginosa in IV drug users. Subacute osteomyelitis is typically caused by Mycobacterium tuberculosis or Brucella. Children with sickle cell disease are at increased risk for Salmonella osteomyelitis, sternum being the commonest site. Site vertebrae are the most common site of hematogenous osteomyelitis, but infection may also occur in long bones, pelvic bones, and the clavicle. Clinical manifestations: patients present with fever, local pain, swelling or redness, point tenderness, and difficulty in movement. Diagnosis: a small piece of infected bone from the most soft and necrotic area may be obtained for culture. Small bits of bones can be ground with sterile broth to form a suspension for bacteriological culture. Blood cultures may be useful in the case of hematogenous spread of infection. Bone biopsies may be sent for histopathologic examination and culture. Radiology: X-ray finding includes periosteal thickening. CT or MRI scan may reveal the extent and location of osteomyelitis. Treatment: early institution of pathogen-directed appropriate antibiotic therapy is the mainstay of the treatment. Surgery: extensive debridement of necrotic tissue is indicated if the patient has not responded to antibiotics or there is evidence of persistent soft tissue abscess or concomitant joint infection is suspected. Now, infectious arthritis. Infectious arthritis refers to inflammation of the joint space due to microbial infection. Pathogenesis: infection of the joint usually occurs secondary to hematogenous spread of organism or as directed extension of infection from the bone. It may also occur following injection of corticosteroids into joints or after insertion of prosthetic material, example total hip replacement. It usually involves single joint monoarticular, but hematogenous spread may lead to polyarticular infection. In bacterial arthritis, knees and hips are the most commonly affected joints. Etiology: bacterial arthritis, overall Staph aureus, most commonest agent of Streptococcus pyogenes, are the most common etiologic agents of septic arthritis, accounting for approximately 70 to 80% of infections. And gonorrhea is isolated most frequently in young adults and Haemophilus influenzae in children less than 2 years of age. Pseudomonas aeruginosa and E. coli are frequently isolated in IV drug users. Among anaerobic bacteria, bacteroids may be recovered. Rare causes include Lyme arthritis, Borrelia burgdorferi, and rat bite fever due to Streptobacillus moniliformis. Chronic monoarticular arthritis is frequently due to mycobacteria, nocardia, and fungi. Viral arthritis are the important cause of infectious arthritis virus. Arbovirus such as chikungunya and Zika virus. Chronic hepatitis B and C infection due to the immunocomplex depletion. Parvovirus B19. Parasitic arthritis may be seen occasionally with ranunculus medianis or echinococcus granulosus infections. Prosthetic joint infections: majority of infections occur during or immediately after surgery caused by Staph aureus, Staph pyogenes, and enteric bacilli. Some infections may occur more than 1 year after the surgery caused by less virulent organisms such as coagulase negative staphylococci or diphtheroids. Now, the reactive polyarthritis is seen in approximately 1% of non-gonococcal urethritis and 2% of enteric infections, particularly those due to Yersinia enterocolitica, Shigella flynexi, Campylobacter jejuni, and Salmonella species. Only a minority of these patients have the other findings of classical reactive arthritis, including urethritis, conjunctivitis, uveitis, oral ulcers, and rash. Most patients are male, have genetic predisposition, have been linked to HLA-B27. Diagnosis: synovial fluid may be aspirated and sent for gram staining and culture. Specimen can be directly inoculated into blood. culture bottles for better recovery. The use of microbacteria and fungal media must also be considered. Now, lastly, the infections of bone marrow infection, where the bone marrow involvement is common, include brucellosis, enteric fever, histoplasmosis, blastomycosis, tuberculosis, and leishmaniasis. More bone marrow culture is preferred for Brucella, Salmonella, S. typhi and S. paratyphi, and fungi. Amastigote forms of leishmania can be visualized in smear or sections made from bone marrow material. In HIV patients, certain opportunistic pathogens may cause disseminated infection infecting the bone marrow. Example: cytomegalovirus, cryptococcus, and mycobacterium avium complex. Okay, so this completes our chapter. Now, the expected questions. A 72-year-old male diabetic patient admitted to the hospital with complaints of swelling in the arm with pus discharge. On physical examination, the local area was found to be red, warm, tender. Swelling has feel of fluid when pressed. Pus was aspirated, sent to microbiology laboratory. What is the clinical diagnosis? So this is the case of abscess clearly. And the etiological agents we can write the infections manifestation, the various ways of one wound infection, and the patient with diabetes mellitus. Why are they prone to infection? All this we can write based on the text that we have read. Okay, so this completes our introduction to the unit, and next we'll be starting with staphylococcal infections. Like, share, subscribe. Thanks for watching.